We've got the second round of the hearing sessions of the London Health Commission. We're hoping to talk to a whole range of patients and clinicians about a number of areas which include what we can do to keep Londoners healthy and what we can do to better engage patients in the design of the care around them.
How is the system helping you to stay healthy? If your commission can get to the stage where it says something generationally driving, then no matter how many times the health service is reorganised, the message is out there and in the community.
Sometimes people don't really understand that they need to eat healthy until something life-threatening happens to them or someone around them. And my auntie had type 2 diabetes, and that kind of made me realise that you need to fix up your diet, eat healthy, and people need to understand that not everything's going to be served for them, that they need to do stuff for themselves.
And my mum and my dad also encourage me to go out and do stuff. So I don't think social media always distracts everybody, because some people do choose to go out. It's just those lazy people who decide not to do it.
Actually, children are not just autonomous beings, they have parents. And actually one of the things we can do to improve the situation for children is actually to improve parenting skills.
I think a big aspect of it is education. For me, it was only when I came to university and started learning about this stuff, the effect it has on the body, that I thought actually this isn't such a good idea and I should look at my diet and eat better foods.
A lot of young people are easily deceived and they just want to follow what other people are doing. So I think we should use the resources and the people we have in the community to boost up and advertise healthy lifestyle.
We can take students and try and encourage them to become part of the healthcare system. We also need to think about how we can integrate healthy eating into a curriculum a bit more deeply.
If you dig down into what influences lifestyle choices in very disadvantaged families, for example, actually some of the decisions that they make, which we would consider to be very unhealthy, are pragmatic in terms of, for example, their level of income. Again, there might be, in some areas a bit too much focus on what you shouldn't do, rather than what you should do.
It's really easy to recognise the people who will become socially excluded. I can go to a nursery down the road and I will tell you who's going to be in Providence Row in 30 years' time. It's very easy, you can see what's there, and there are plenty of things to do about it. Social exclusion is a process. The reversing of it is a process. It falls, I think, in public health, but it also involves mental health.
For me, participation and peer support changed and probably saved my life.
People who deal with planning and engineering the streets and transport systems here, it does affect absolutely every Londoner, encouraging people there because they don't get the everyday exercise.
With support from general practice nurses and other allied health professionals, dietitians, to do exactly what you're talking about, to visually show and to have group discussions and bring that as part as your work, your school day, to make that a routine that you're learning about not just sugars but fats and exercise, but make that routine and a normal thing that happens in school.
Many of the people we see are effectively the product of failure of the system, that when bits of it don't work, you end up in A&E. It's the only place that's always open.
The access to general practice in London isn't as good as we'd like it to be. And also we know that, in fact, you look at the studies, if you've got good access to your general practitioner, you have less use of A&E, you're admitted less, you attend less, and your patient outcomes are better.
There's an awful lot of different bits of information in different places, and one of the ways in which we could really improve healthcare, both in the secondary centre and tertiary centre and in primary centre, is by joining up that information that we have. In the days of Google and the internet, patients expect to be able to get instant access to information about themselves and their healthcare, as well as everything else that's going on in the world.
There's a lot of bad language being used around this table. Primary and secondary, one person did say to me, does that mean primary is better than secondary?
With our ethnic diversity, we have actually got one thing in common. Virtually everybody has a mobile phone. What it can't do at the moment is actually contain your personal medical record as a person and a patient, nor can you arrange your healthcare through it.
I think with regards to digital technology, it's one thing just to access your medical records. The next step is actually to input your medical record.
When people are discharged from hospital, they feel that hospital is the only place that they can be treated. Therefore, you need to do something to sort of give confidence to the public that they can receive excellent care within the community setting.
We almost need a directory for everyone to know what is available, because I don't know everything that's available. I know in this locality. So we really need somebody to shout out to say, this is what we can do, this is what is available.
There is massive variation about what the definition of a community is. And there's massive variation about how easy they are to relate to if you're a provider organisation. The new reorganisations within the health service have far from simplified that relationship. They've made it much more complicated.
As people, we are programmed to form relationships with other people. We're not really hardwired to form relationships with systems. You know, they're kind of mechanical things. People, I think, do well if they know somebody who they can turn to, and if that person is around for a significant period of time, there's continuity. And we have lost that a bit in health and social care.
There's a sense that because we're not necessarily health experts, that we don't always know what we're talking about. And actually, I think there are times when we have a much better, much more open and transparent relationship with harder to engage members of the community.
The thing that is amazing about cities is that they're full of all sorts of different people, and they're dynamic, and they move and they change, and we as a voluntary sector and the healthcare sector have to change with them and be dynamic as well.
Pretty much all my behavioural change interventions are now funded by the private sector, or they are dependent on the private sector to be delivered, because it's about getting interventions timely with an ask that the public can follow. And that's not necessarily the NHS, because they're posts of the sickness bookkeeping, they're further down the field.
We need to do things radically different. It's a time for generalists now. People have a responsibility across a range of issues. No longer can we deal with a specific illness. You need to deal with the whole person, and you need to deal with the family behind that. And for us, that's the integrated care.
The 20th century was a century of evidence-based care. The 21st century is a century of personalisation. It is about the people themselves.